What's up, ultrasound people? How you doing? Miram and Larry, UCSD Department of Emergency Medicine. We're going to talk about ocular ultrasound. So, first question we want to ask is, why use ultrasound for the eye? The reason is that, number one, physical exam can be very difficult in these patients, particularly the ones with facial trauma, severe edema, subcutaneous air, etc. And number two, ultrasound is often more accurate than our physical exam in diagnosing many diseases such as retinal detachment, penetrating globe injuries, and papilledema. Lastly, the eye is fluid-filled, making it ideal for ultrasound. So let's discuss a little bit about the anatomy. Notice here the cornea, the pupil, the lens, the iris, the retina, the macula, the fovea, and the optic nerve. Let's take a look at an ultrasound of the eye. As you can see here, we have the anterior chamber, we have the iris, we have the pupil, we have the posterior chamber, the lens, the vitreous, and the optic nerve. A few words about technique. We want to use the linear transducer, plenty of gel. We want to use the pinky finger to stabilize the hand so that there's no pressure on the eye. We like to use Tegaderm to protect the eye, and make sure to use the proper gain, and if at all possible, put it on the ocular setting. Here's an example of the Tegaderm, and here's an example of the pinky finger stabilizing the hand and the probe so there's not a lot of pressure on the eye. Here's Dr. Colleen Campbell, who is going to demonstrate how to perform an ocular ultrasound. Hey guys, this is Dr. Colleen Campbell. She's performing an ocular ultrasound. And first thing I want to point out is how Dr. Campbell is holding the probe, resting it gently on the eye, and being careful of how much pressure she's putting on the eye by using her pinky to stabilize her hand and the probe. Okay.
So what we see in the eye here is the anterior chamber, the posterior chamber, and the vitreous. And then back here is where we're going to find the optic nerve, right here. And that should be 5 millimeters or less, unless you have increased intraocular pressure. And then sometimes you'll see a cupping right in here. When we look for retinal detachment, we look back here for a detachment. And Matt, can I have you look to the left and look to the right? Good. Right now my probe is transverse, and I'm going to turn it to a long view. And let's get rid of a little bit of depth. And again, we see that anterior chamber, the posterior chamber, and the vitreous.
Looks like you're catching a little bit of the lens there as well. Okay, guys, let's move on to a trauma assessment of the eye using ultrasound. And thank you to Colleen for instructing us on how to perform the ocular ultrasound. So with trauma, there's a few things we look for. In this clip, you can see the right eye labeled OD, which is good, and the left eye labeled OS, which is looking like an anterior flattened anterior segment, lots of gray heterogeneous material in the vitreous, kind of an abnormal shape of the eye, and those are all findings that are consistent with a globe rupture. Here's another visualization of a globe rupture. As you can see, again, it looks pretty much like a jumbled mess. The anterior chamber is so flat you can hardly see it. There is lots of blood in the vitreous. We can't even really see where the lens is right here, and the eye is not round, Also, as you can see, the lid above the eye is swollen and edematous. Here we have an image of a hyphema there in the anterior segment. And here we have a dislocated lens which has collected all the way down in the posterior aspect of the vitreous. Lastly, we have a foreign body that can be visualized here, signaled by the arrow. So let's move on to retinal detachment. The important thing to realize with the retina is that it's tethered to the iris anteriorly, or the ciliary body anteriorly, and the optic nerve posteriorly. So it has to be tethered to those two spots, or else what you're looking at is not the retina. And we'll see some mimics of the retina, mimics of retinal detachment, but those will not be tethered, as we will see that the retina is. There's a couple of classifications for retinal detachment. You can look to see if the macula is on or off. The ophthalmologists like to know this because the urgency of the surgery is more so when the macula is on versus when it's off. So here we see clearly the retina is peeling off the posterior segment of the eye. And as you can see, it is tethered anteriorly to the ciliary body and posteriorly to the optic nerve. Here's a clip of a retinal detachment. As you can see, when we scan through the eye, we can see that the retina is indeed tethered to the optic nerve sheath, and it appears, if you look a little bit temporally, that the macula is indeed off on this retinal detachment. Some mimics of retinal detachment, as we discussed, there's two that I want to talk about. One is posterior vitreous detachment, and the second is vitreous hemorrhage. So with posterior vitreous detachment, it will not be tethered. The symptoms are flashes or floaters. There's actually no treatment for posterior vitreous detachment, but it does need to be followed to make sure that it doesn't evolve into a retinal detachment. And the mechanism is that the vitreous liquefies, it shrinks, and it detaches away from the retina. And the causes include age, advanced age, myopia, and post-cataract surgery. Here's a clip, I believe, of a posterior vitreous detachment. As we scan through the eye, you can see that there's the optic nerve sheath, and clearly it is not, this entity is not attached or tethered to the optic nerve sheath. Sometimes it can have the appearance of clothes in a dryer, as witnessed here. You can see, here's an example of kinetic imaging where the operator asks the patient to look towards his left or right, and you can see the movement of the vitreous detachment inside the globe. So vitreous hemorrhage, on the other hand, is bleeding into the vitreous humor. The importance of that is that up to 85% of them may have an underlying retinal detachment. So it's important, even if you see a vitreous hemorrhage, you do need to consult your ophthalmologist on these. The symptoms of these are flashes, floaters, and sometimes vision loss, particularly if there's a thick amount of hemorrhage. The vision loss, it could be kind of an orange haze in front of the patient's field of vision, or if there's a retinal detachment associated underneath it, they may just have complete loss of vision in that location that corresponds to that part of the retina. So here we see some hemorrhage in the vitreous. As you can see, the blood looks gray, it looks heterogeneous, and it's not tethered. Sometimes it can layer out, as seen on this image. A few pearls and pitfalls for the performance of ocular ultrasound. before we go. Apply lots of gel. Avoid pressure on the eye. Beware of the mimics of retinal detachment. And we should discuss, there is one more pearl. What? Oh my god. Stop. Stop. You're a fool. You look foolish. You look foolish.